I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Hegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
72-year-old woman with a left ER and PR negative high-grade ductal carcinoma in situ found on screening mammography. She underwent a partial mastectomy with positive margins. Found on post-operative MRI to have suspicious internal mammary lymph nodes with FDG avid nodes on the PET scan. And so the question here is really, what are the next steps in management? What's the recommendation for additional workup and or proceeding with treatment? And then in terms of sequencing of therapy. So again, we might just start with Dr. Jockelson walking us through this MRI and subsequently the PET scan.
So, I mean, I think the crux of this is that you have a patient who, as far as I could tell, only had DCIS and is now, after surgery, presenting with internal mammary nodes that are enhancing. The size of the nodes, the one on the right's not that big. The one on the left looks like it's over 1 centimeter in size. There's no definitive size that is negative or positive with internal mammary nodes, but if you read the literature, some people use 5 millimeters. So anything over 5 millimeters is very concerning. She doesn't apparently have axillary adenopathy. She had nothing on her, I mean, they didn't do a sentinel node because she had DCIS. So what you have here is internal mammary nodes without an obvious etiology. One possibility, she might have another tumor. She might have lymphoma, some sort of systemic staging just to make sure that she doesn't have nodes elsewhere and this is not related to her breast cancer. So again, I have these images from the PET scan. I presume that there were no other nodes anyplace else. So now what you can do is do an ultrasound. You can biopsy internal mammary nodes with the fine needle. I mean, not always easy, but you can ultrasound and sometimes do a fine needle aspiration and in the right hands get a reliable diagnosis. And I think you need to find out what this is pathologically because you certainly can't assume that it's related to her breast cancer.
Perfect. Okay. So in terms of the next step in management, you think Dr. Jockelson to attempt biopsy of that internal mammary lymph node and that would really be the wisest next step?
Yeah. I mean, we've certainly done them, and the one on the left is fairly big. So I think that's, no meat, no treat.
Yes. Thank you. Well put.